sessions, as you know, are held weekly on a Wednesday. The chat will be open for questions. If you have questions, you can either just put them, you can just type them in the chat, or after each presentation, we will discuss them. The first presentation is going to be by Malini Bana, and it's normal AFP in hepatocellular carcinoma, friend or foe. Malini.
I'm just going to share my screen.
Yes. Yeah, we can see that.
Okay, great. Okay, so my topic today is normal alpha-fetoprotein HCC. I'm going to start off with the case presentation of a case that we had recently here. Okay, so we had a 45-year-old female who presented to her GP initially, complained of a sharp right-sided abdominal pain of about a year's history, now significantly worsening. Also had associated loss of weight. And on history was also noted to be postpartum, currently breastfeeding. On examination, the only significant finding was a palpable liver, which was enlarged, but non-tender. She was not jaundiced and no signs of anemia. These were her laboratory tests when she came in. Essentially a normal white cell count, normal U&E. Of note, hepatitis A, B, and C was all negative. She's HIV negative, and her AFP came back as 6.4, which is the normal range. So this is a CT scan. I'm going to start off with the arterial phase. So we can see here, the chest, there was no lesions, although this is not a lung window. Okay, so you can start seeing multiple liver lesions, bilobar lesions, significant contrast uptake here, and really what looks like a multifocal HCC with a dominant central lesion. We move on to the portovenous phase. You can see similarly here, the lesions are still visible, but the contrast is washed out. The left portal vein here, you can see, is also severely attenuated to the point of being completely cut off. Okay. So what next? So we had this lady with a low AFP, but a lesion that on imaging looked very suspicious for HCC. So in view of her age and this low AFP, we decided to do a liver biopsy, and the histology came back confirming hepatocellular carcinoma. So as we know, HCC is the commonest primary liver malignancy worldwide. The majority of patients present at a late stage with advanced disease and really have quite a poor prognosis. Our diagnosis relies primarily on biomarkers and radiological features. And in order to make an earlier diagnosis, effective screening methods need to be employed, of which AFP is one of the most widely used biomarkers. Generally, an AFP of more than 400 is considered diagnostic, but we'll look at the levels and what they really mean a little bit later. But it's important to note that up to 50% of patients with HCC actually have normal AFP levels. So what is alpha-fetoprotein? So like I said, the most widely used biomarker. It is normally produced during fetal development by the yolk sac. After birth, levels drop quite rapidly, and by the second year of the infant's life, only trace amounts are actually present. So if we look at the molecule itself, it is a V-shaped molecule, and it's an oncofetal glycoprotein with a single polypeptide chain of 600 amino acids and 4% carbohydrates. It shares many structural and physiochemical properties with other proteins like albumin and vitamin D binding protein. And in fact, AFP is suggested to be the embryonic equivalent of albumin in the adult. So what it does is it carries proteins, hormones, bilirubin, and fatty acids in the fetus. And other important functions is that it can also stimulate cell proliferation and cell motility. And that's really where its oncogenic properties come in with increased risk of metastases and cell proliferation. So if we break it down even further, AFP has 3 isomers or glycoforms that you can see. So there's an L1, L2, and L3. And the ones that are significant to us is L1 and L3. So it's divided into these 3 based on its binding affinity to the LCA lecithin. And L1 and L3, like I said, are the important ones. L1 isoforms are ones that bind to inflammatory liver disease. Now, this is non-HCC inflammation, and it's usually from things like non-alcoholic, like NASH or NAFLD, is the ones that it's important for. L3 is for malignant tumors, and that's associated with hepatitis B, C, and cirrhosis, and it is for those purposes that you would use the L3 isoform. So how is it measured at the laboratory? So originally, the method used was electrophoresis. We've obviously changed now to use enzyme immunoassays or ELISAs. And how it works is, this is the AFP molecule, and you have 2 antibodies that bind to it, which creates this luminescent reaction, and that's what's picked up. You can get false positives if 2 of the antibodies are bound to a heterophilic antibody, which is an autoantibody that is produced. And you can similarly get false negatives if it binds to the antibody without binding to the antigen itself. Okay, so how accurate is an AFP, and what is the sensitivity and specificity? So there's a number of studies looking at this, and this is from a systematic review looking at the AFP cutoff value. And it really depends what level you look at as to what is the sensitivity and specificity. So if you start with an AFP of 20 as the cutoff, and that's largely what is regarded as the normal, the sensitivity is approximately 60%, and the specificity is 90%. So if you increase it going up to 400, which is usually what we use as a diagnostic purposes, you can see the specificity really goes up all the way to 99.4, but at the cost of a much lower sensitivity of only 17%. So what is normal AFP HCC? So is it HCC with a lower or just a normal AFP production? Are the radiological features the same as with raised AFP HCC? Is it a distinct subtype? And are survival outcomes affected? So these are just some of the questions I had when looking into this topic. So we'll start off with the definition of it. And really what I found is there is no accepted or agreed upon definition for normal AFP HCC. Centers tend to use what is used in their own institutions. So if their normal AFP cutoff is 20, then that is what is used. In general, if you follow the American guidelines or the AASLD, then a cutoff of AFP of less than 20 would be a normal AFP HCC. A lot of Asian studies, however, do use values of less than 15 and some also less than 10. If we look at the radiological features, are they the same as for high AFPs? I found this study was sort of the only one really commenting on it. So this was a single center retrospective study done at UCLA and published in JAMA. So they looked at, I think, about 660 patients who were all candidates for liver transplant with HCC. And they looked at about a third of those patients were non-secretors or normal AFP HCCs. And what they found was that in terms of radiological criteria, the tumor characteristics were very similar to those of patients with AFP producing tumors, but they tended to have fewer lesions. So 10% less of them had more than 2 liver lesions, so fewer liver lesions and smaller cumulative tumor diameter. So 4.2 versus 5 centimeters, so not really that significantly different. We look at survival outcomes. This was another very large study, this was multi-center, but a Chinese study looking at more than 80,000 patients with HCC. And what they showed in terms of survival outcomes, they grouped it into 3 groups. One group was where surgery was not performed, and that's the first one. The second one was where surgery was recommended, but wasn't performed. And then the last one was patients who underwent liver transplant. And they found that really in all 3 groups or across the board, survival outcomes were improved in patients who were negative AFP prior to surgery. Okay, And above that, the study also showed that actually a low AFP is an independent risk factor associated with tumor differentiation, the TNM stage, tumor size, survival of patients, as well as outcomes post-liver resection, because the AFP level at diagnosis was an independent risk factor for survival, right? So really what it tells us is that AFP positive tumors tend to be more likely, poorly differentiated at an advanced stage, larger tumors, and inferior survival. This was another study done in Italy, also similar outcomes of more than 1,000 patients. Essentially, the prognosis, if we look at across all of these, that is that AFP that is higher is really a predictor of worse mortality in these patients. And then in terms of clinical pathological characteristics, normal AFP HCC is associated more with NAFLD and less with hepatitis B and less with alcoholic cirrhosis. They also tend to be less likely to be poorly differentiated, less likely to have micro or macrovascular invasion, and lesser size or tumor burden. So really good clinical pathological characteristics. So what are the roles of other novel biomarkers? We know that there are quite a few that are coming up. There's protein-induced vitamin K, absence in and AFP-L3, which I've already mentioned. Ultimately, none of these are used in any Western guidelines. They still have yet to be validated. And just remember that AFP is not only raised in HCC, but also in many other causes, including non-hepatic tumors like germ cell tumors. But in conclusion, I think this normal AFP HCC really creates this strange or interesting dichotomy where you want an AFP for diagnosis, but having a higher AFP really is a worse prognosis. So AFP is essentially a prognostic marker associated with increased tumor virulence, associated with a worse tumor phenotype and more aggressive aggression. AFP has a role in prognostication, but it is important to remember it's not the only determining factor. And while the studies I showed you did show worse sizes and burden of tumor, there are others that show actually similar sizes and presentation of patients with low AFP tumors. So while it is a factor, it's not the only determining factor. One should also consider individualizing therapy in these patients, and especially in patients who are AFP positive, with possible adjuvant treatment required aside from the surgery, and really more research is required into this field. Thank you.
Thanks, Malini. If anyone has any questions, they can just raise their hand or put them in the chat. So just one thing that I didn't quite get with when you were saying, I think you were saying the low levels, are they less likely to be associated with hepatitis B and more likely to be associated with
low levels of AFP are less likely to be associated with hepatitis B or alcoholic liver cirrhosis.
Okay, so it's more common with NASH.
Yes.
Okay. All right. And like you know what, when you mention the prognostication, I mean, we tend to not list people for liver transplantation if the alpha fetoprotein is greater than 500. But when it's high and we do some form of local therapy and there's a good response, you know, that obviously we feel like that's a good prognostic sign. But you don't get that obviously in these patients with the low alpha fetoproteins, so you lose out on that. Just another question. So just if you come back to that patient, how are you going to treat that patient?
So we discussed this at our MDT, and the decision was really that to offer her TACE.
Okay.
We don't have sort of or anything else available.
Yeah. So the one other thing I suppose is if TARE wasn't so expensive and was more widely available with the portal vein invasion, that might be a good option in this patient. The other question, you know, so like you mentioned, if that patient had an alpha fetoprotein about 400, we wouldn't normally have done a liver biopsy.
Biopsy.
And you know, we always worry about missing a diagnosis. I think when you have tumor in vein, it is easier to make the diagnosis. But I do also feel like the pendulum is swinging a little bit towards doing biopsies again, because the degree of tumor differentiation, or if it's well differentiated or poorly differentiated, also has good prognostic yeah, like is a good prognostic sign. I don't think there are any questions. So I think what we'll do then is we'll move on to the next presentation by Sanju Sobnach, who's another of our fellows. He's actually doing his PhD in hepatocellular carcinoma, and the topic of his talk is hepatitis HPV-related HCC in the HIV era, and an unlucky trifecta. Should it not be bifecta?
Yeah, Mark. Can you hear me?
Yeah.
Okay, so essentially I was tasked today to look at HPV-related HCC in the HIV era. The trifecta here is the hepatitis B, the HCC, and the HIV.
Okay.
That's
Nice.
quite an unlucky combination of problems to have. Just some background, HCC is the largest cause of cancer-related mortality worldwide. It's actually the third largest, and viral diseases, so hepatitis B and C, are well
Sanju,
recognized.
we're not seeing your screen.
Can you see it now? Hold on. Is it fine now?
There we go.
Yeah.
Got it.
Yeah. So I was saying HCC is the third largest cause of cancer-related mortality worldwide. Viral diseases like Hep B and HC are well-recognized etiologies. And coincidentally, people living with HIV, it's PLHIV, that's what the nomenclature is in the literature these days, have a high prevalence of hepatitis B. Sorry, that's supposed to be hepatitis C instead of HIV in that line. And the unlucky trifecta here, as I said, is HIV, the Hep B positivity, along with HCV and the HCC. So what about liver cancer-related mortality? There's a massive French study conducted in 2010 where they looked at liver-related deaths in HIV-infected patients. In France, they called it the Mortavic study. It's completed in 2010. And they looked at 26,000 HIV-positive patients and followed them from 1995 to 2010. And over that period, 230 died. And when they looked at the incidence or the prevalence of HCC in 1995, it was 5%, and then it quickly ascended to 40% by the year 2020. And again, as is in most high-income countries, HCV was the main etiology and the cause of liver-related disease in these patients. And this is the chart from the same paper looking at mortality rates from liver-related or AIDS-related or other causes for these patients in this study. And again, if you look at the liver-related group, although the groups are still small, the issue of liver-related mortality is slowly creeping up. So why does this happen? Well, there are many postulates for that. The first one is that HIV-mediated impairment of antiviral CD4 and CD8 cells, that leads to a rapid progression of fibrosis and eventually creates an environment that is suitable for the formation of an HCC. The second postulate has been that of increased oxidative stress that's associated with the administration of HAART. Then there's issues with the microbiome, so HIV-associated gut dysbiosis, mainly in animal models, and then the high incidence of alcohol in patients who are HIV positive, and that is certainly very well documented in sub-Saharan Africa. So again, the predominant theory behind this is that the patients have impaired T cell function, and there's rapid fibrosis, cirrhosis, and malignancy. the big issue I have with this is at the moment, when we looked at this in our cohort, we were about 681 patients, so 50% of them are cirrhotic and 50% of them are non-cirrhotic. So it's almost an equi-split in the middle. And whether that theory still holds in our setup is really questionable. So David Panato is well known and has done a lot of work on HIV-associated hepatocellular carcinoma. Has looked at whether there's integrated phenotyping of anti-cancer immune responses in HIV-associated hepatocellular carcinomas. And what they've done, which I think we could do quite easily in the future, is they've taken tissue from the tumor itself and from areas around the tumors, and have gone to do what they call multiplex immunohistochemistry, essentially complex techniques to look at antibodies against CD4, CD8, FOXP3 and PD1 cells. And what they've gone to show is that essentially what they've done is they've taken resection tissue from 66 HIV positive and 63 HIV negative patients. They've done this immunohistochemistry. And what they've shown is that there's increased PD-L1 cells and Tregs and a large amount of immune exhausted CD8 cells in these HIV positive patients. And that results essentially in downregulation of gene signatures related to immune responses to HIV. And they found no association between HIV infection and how T cells essentially make clones. And if you look at the data throughout, throughout the world, the data is very conflicting, it's scanty, it's fragmented. What we have in most studies is multi-center studies from high income countries with individually very small numbers from designated centers. Most of the data is either Italian, Spanish, there's some US and Canadian data in the literature. And most of the time, the HCC outcomes in these papers is for hepatitis C positive patients. A split there is 80% to 20%. And there are a large number of Italian studies looking at liver transplantation in HIV positive patients with HCC. And the data, again, is very conflicting depending on which center you read from. So this was another Italian study that looked at hepatocellular carcinoma in HIV-infected patients. And their theory was that you should check early and be very aggressive with the HIV treatment in these patients. I just want to point out again that if you look at the mean age of these groups, the HIV positive group is 48, and the HIV negative group is 67, and these patients are generally younger. Again, one looks at the etiology of the chronicity of the liver disease, and you see that HCV dominates this group. So 53.8% of patients had hepatitis C positive in the HIV population, and only 10% were HBV related. And looking at survival outcomes, certainly what this paper showed was that the p-value of 0.04 just there, that these patients have poorer survival irrespective of their type of So it's another large paper published in AD Veterans Data. This was multi-center, just as the previous study, and looked at outcomes in HIV positive and HIV negative patients. You look here, HIV positive 200, HIV negative 200, 1-to-1 match. And again, the patients who were HIV positive were significantly younger. They were predominantly African American. But surprisingly, in this study, a proportion of these patients had hepatitis B, and that was 19.5, let's say 20% of apologies. So yeah, 20%, but Hep C again predominates at about 86%. And these patients were less likely to be transplanted compared to their negative counterparts. And this is just looking at their treatments that they were offered. And here, once again, we look at the Kaplan-Meier. It looks as if that the HIV positive patients do less better, but in this case, the p-value is 0.1, so it's not significant. The next two papers are probably the largest series in the literature. paper by Brow et al. That looked at a US-Canadian multi-center study, again, looking at the outcomes of HCC and HIV-infected patients. Let's look at the numbers again. HIV positive, 63, HIV negative, 226. Again, the patients are younger, predominantly African-American, and HCV predominates that group again. And the patients who are HIV positive tend to drink more. Now, if we look at the outcomes in this group, HIV negative versus HIV positive, they've then looked at HCV monoinfected versus infection with HIV and HCV. Although the trends do show poorer survival, the absolute values mean nothing. The p-values in this case were all above 0.05. Therefore, these findings were not significant. And probably the largest study that's been published, again by David Pinato in JCO in 2018, looked at the influence of HIV infection on the natural history of HCC, and that was a global multi-cohort study. I just put these figures here to show you how much they actually have to salami slice this data. The liver cancer in HIV was 613. Then they took patients from the Italica group, from a whole consortium of hospitals in Italy. Then they took patients from SGH in Singapore. Concerns there because not every single center treats patients in the same way. At Singapore General, it's an Asian center. They're often much more aggressive than what is available in Italy, but obviously Italy does more liver transplantation than Singapore itself. So it's quite heterogeneous of what's been offered to these patients. Again, if you look at the data, generally younger patients. In this group, the hepatitis B goes slightly higher, and that's probably because of the Asian data, the Asian contribution to this study. So 25% of the HIV positive patients are co-infected with Hep B, and in the HIV negative group, that goes up to 45%. That looks more like Asian data rather than data from Europe or North America. And again, these patients have lower albumin levels and more liver dysfunction with higher levels of ALT and AST. But in this study, the p-value is less than 0.001. So HIV positive patients do survive much longer than patients who are HIV negative. So what about some African data? There are actually only 2 papers out there. This one is quite a recent publication from the this cohort. 83% are HIV negative, 17% are positive, so only 36 patients in there. Really, the only thing that's significant is that the patients with HIV have lower HBV viral loads compared to their negative to the positive partners. And in this case, the survival is absolutely poorer in the HIV positive group, and the p-value for that is 0.038. Second paper is from Uganda, looked at the impact of HIV infection on clinical presentation on mortality in Kampala, and similar findings. Again, obviously patients are younger, and if you look at the hepatitis B surface antigen rate, it's quite high. It's about 43–44%, so about half of the cohort. That looks more like what we would see in South Africa. These curves are a bit strange for me. These look like upside down Kaplan-Meier curves. And it was interesting to see that there wasn't really a difference. The only difference that they noted is that the p-value was 0.05. They did call that significant in their paper. And that was when they looked at low CD4 versus high CD4 counts. I'm only going to show 2 slides regarding our data at the moment because we are busy writing this manuscript and I actually don't want to contaminate the data. We've looked at all our HCCs from 2012 to 2024. That's because we started doing VCT for all of our patients from 2012 in the unit. We had 478 HCC patients. In this cohort, our follow-up was 90%, and 272 were hepatitis B related. And 306 were HBV negative. And in the hepatitis B positive cohort, 67 had HIV. So almost 1 in every 4th patient in the Hep B positive cohort had co-infection with HIV, which is extremely high. And without surprise in our cohort, certainly when we look at the Kaplan-Meier, the p-value approximates 0 in our cohort. Our patients actually survive much less than the HIV negative counterparts. I'm going to stop here. I think that's the end of my talk, and I'm going to be open to questions if there are any.
Thanks, Sanju. Interesting data. I just want, if anyone has any questions, if they can just raise their hand or just put it in the chat. So my understanding, Sanju, is that HIV itself is a risk factor for the development of hepatocellular carcinoma.
Yeah, there is some data to suggest that.
You muted.
Sorry. Can you hear me?
Still can't hear you.
Yes, I can hear you.
Can you hear me now?
Yes, I still can hear you.
Okay. So I think Mark.
We can't hear you, Sanju.
I don't think Mark can hear, but we can hear you, Sanju.
Can you hear me?
Sorry about that. Yeah, okay.
Yeah, and I think the data does suggest that HIV positive patients are more susceptible to HIV. I'm really not sure whether it's an intrinsic factor itself or whether these patients have occult Hep B. I think certainly that's one issue that we've been looking at and seeing in the data. A lot of patients are HBV surface antigen negative, but when you do their core, they're invariably positive. And I think not many centers are doing core positive testing, especially in our environment. It'd be interesting to dive deeper in our data and see if that actually is.
Yeah. No, so there's a
You're muted.
So Sanju, yeah, there's an increased incident. There's an increasing incidence of non-AIDS defining cancers in patients with HIV, and I was just looking at hepatocellular carcinoma seems to be one of them. So I just see there's a question. It seems heterogeneous populations. What do you think the driver of HCC, seeing the baseline characteristics are different? Is it the etiology, HPV versus HCC versus alcohol, aflatoxin, or genetics? I don't know if you want to comment. I can maybe say something about
look,
that.
I think in most studies, the data is very heterogeneous. In our study, we have 73 HIV positive, of whom 67 are in HPV-related patients. And in the remaining lot, we didn't call them HPV because they were not tested for it. So we decided to exclude them. But I think in our setup, the etiology will be hepatitis B. I think in high-income countries, although there are many factors, it will be HCV. I think that's a predominant etiology. Aflatoxin has been a real mystery for us. We have some samples in the lab, and we will do some aflatoxin assays. I don't think it's the predominant cause in our setup, and I say that with a lot of humility. I think that is yet to be proven in our cohort. Genetics, a bit mysterious. I must say, in our cohort of 681, we had close to 10 patients where an entire family had HCC. So brothers or sisters, and it was very well documented. And some of these patients actually are in the database. Siblings are in this database. That sounds more like it's HPV related. They all had HPV or were carriers from a very young age. But again, it could be multifactorial. But that is yet to be proven. I think the way to do this is some of the immunohistochemistry we'll be doing on some of the tissue. I think that will give us a lot of answers. And the other lot is the spatial transcriptomics work and the single cell work that's yet to come probably over the next few weeks. I think that will give us a number of the answers.
So another interesting thing was I see that in our data there was the HIV patients tended to have a lower hepatitis B viral load, probably because they were antiretroviral therapy.
Correct.
And I know Professor Spearman has said that in Africa, often patients who are co-infected Hep B and HIV, the Hep B is often treated better because of the HIV and patients having good access to antiretroviral therapy, where there isn't often as good care for patients with hepatitis B. You wonder if having HIV, once it's picked up and getting onto antiretrovirals, maybe by being on the antiretroviral therapy and treating the Hep B, you decrease your chance of getting HCC. Did you look at the viral load, like the hepatitis B, the HIV viral load, and the effect on outcomes?
Yeah, so we have we had a viral load in 90% of them and a CD4 count. I'll be honest, we haven't done the subgroup analysis yet, but to the best of my knowledge, most of them were LDL, were lower than detectable. Yeah, so a lot of these HIV patients treatment before, and the ones that presented with the HCC and were diagnosed with the HIV then, those are the ones that had the worst outcome. But like you're saying, probably the argument is that the ones that went hard had their hepatitis B suppressed for a very long time.
Any other questions? I think Ed has a question.
Yeah. Stop your mic. Thank you very much, Sanju, for a nice talk. Can you just tell me what is the situation with transplantation of patients with HIV and hepatitis B co-infection? We know we've the program to start renal transplant with HIV recipients from HIV donors was started here in Cape Town. But what is the situation with HIV co-infection in hepatitis B associated HCC?
But it's certainly not an indication. It's certainly not a contraindication, provided that they are suppressed and that the disease is well controlled. If I look at the data for transplantation for HCC in the literature, and those who are HIV infected, being hepatitis B positive was not a contraindication. But certainly what was a contraindication is that if you have high viral loads, you're not suppressed, you haven't been treated. That's an issue. And the other big problem, obviously, in these patients is once you transplant them, the reactivation of hepatitis B is again quite high. They go on heavy immunosuppression, they get a graft that can get fulminant hepatitis. I think that's been well established in our unit here when it's happened without intention, unintentionally.
But HIV positive donors, would they that say deceased donors, are they potential candidates as a donor for a patient with say HCC
there are very few centers. I know the Duke group has done a handful lately, and there's another center in the US that's done it, but I think that I really didn't see any long-term data, and it started only 3 years ago. I know certainly many groups are talking about using it. And for us, certainly that would be an avenue to look at.
Okay, no, thanks.
Yeah, I mean, I think it really does make sense that you could transplant an HIV positive liver in this situation to an HIV positive donor. We haven't done that yet. One of the other things is using like core positive recipients and transplanting them. I think the chance of reactivation of hepatitis B these days is lower with the better with the antiviral therapies that we have now. We haven't done lots of these transplants, but with hepatitis B, we've always tended to give hepatitis B, like intravenous hepatitis B immunoglobulin for the first week and then change it to intramuscular hepatitis B immunoglobulin, and then have the patients on lamivudine and tenofovir. I think if you do that, the risk of hepatitis B virus activation is quite low. I don't have any experience of transplanting HIV positive patients, but as Ed said, the kidney transplanters do, so we could get their advice on how to deal with things. I see there's a comment saying that hepatitis B viral load can be misleading. Integrated DNA is a driver for HCC. Yeah, so I mean, we know that patients who are hepatitis B infected, who've cleared the virus and have no detectable viral load, are still at increased risk of getting hepatocellular carcinoma. And I think that's why we should always check a total core antibody in patients who have a liver mass, because you can be hepatitis B surface antigen negative and still be at risk of getting hepatocellular carcinoma. Are there any other questions or comments? Yeah, I'd just like to take the opportunity then to thank the speakers. Those were really interesting talks. Wait, sorry, so another question. So another question just popped up. Is there a difference between the prevalence of HCC in non-cirrhotic patients in HIV and hepatitis B versus hepatitis B alone? Sanju, I wouldn't know the answer to that.
Yeah, not in our analysis. We actually looked at it 4 nights ago in the lab, and it didn't look that there was any difference. Yeah.
Okay. All right. Okay. And then also just thanks to the iEcho University of New Mexico and iEcho India team. The recordings of this will be available on the Gastro Foundation website. Thank you to the Gastro Foundation and to the sponsors. And the next week's talk will be on patient blood management. Thanks, guys.